Every once in a while, healthcare gets it exactly right. Not only does the evidence support change, but thousands of hospitals adopt that change in just a few years. What had largely remained unchanged for decades suddenly becomes the new standard of care almost everywhere. That almost never happens. So when it does, it's worth asking why, it's worth looking into it and seeing what's going on here. On today's episode, we're going to discuss one of the fastest and most successful national quality improvement efforts ever in modern healthcare, reducing early elective deliveries before 39 weeks. The real story isn't about obstetrics, although there's a piece of it is. It's about understanding what it takes for evidence to move from journal articles into everyday practice, and why this particular effort succeeded when so many others struggle. Hi, I'm Bruce Spurlock, a physician and healthcare leader committed to helping professionals and decision makers navigate change with clarity. On Viral Healthcare, we look at the ideas spreading across healthcare and what it takes to implement them wisely and sustainably. So here's the story. Let's go back 20 plus years. This concept of early elective delivery, that's when women who are less than 39 weeks of gestation, have babies less than 39 weeks of gestation, are electively, that means there's no medical indication. It's because her preference, the doctor's preference, or both, say, let's have our baby when we want to do it. Let's schedule the time and the date. There's a lot of reasons to do that. A lot of it's personal preference. I want this date and not that date. Or the doctor wants to avoid coming in on the middle of the night. But it became an active, accepted practice for women and doctors who decided this, that they should be doing it. But unfortunately, ACOG, the professional organization for obstetrics, had recommended maybe 20 years before that we shouldn't be delivering babies be 39 weeks. And then the studies started coming out that, in fact, those babies actually should have greater problems than they did. Many more of them went into the NICU, the neonatal intensive care unit, than were necessary. Deaths weren't high, but the challenge for having babies that weren't ready to come out, be born, was clearly obvious. It wasn't for a lack of evidence that this information was known. It was well known. It wasn't waiting for another clinical trial. It wasn't this classic evidence to practice gap or controversy that we see all the time. So if everyone agreed about it, why didn't the practice change? Then something remarkable happened, and it was right around 2010 when things changed relatively quickly and dramatically. National early elective delivery rates dropped from around 17% of all babies being born to under 5% in just a few years. The program that I was involved with, the Partnership for Patients, we demonstrated similar national improvements. The idea, though, is not about the numbers. The idea is about the speed. How do we do that in just a couple of years when we had 20 years of inertia? How did that suddenly disappear? Well, let's talk about some of the basic lessons that we learned during that time. Evidence alone rarely changes behavior. That's lesson number one. Evidence alone rarely changes behavior. So we know that evidence is necessary. We know that when evidence is controversial or incomplete, it slows things down, but evidence alone is not sufficient. Healthcare, we think sometimes just publishing articles, showing people the evidence is good enough. And time after time, we've learned that it's necessary but not sufficient. It shows that alone, it rarely or slowly changes practices. And what it means is that knowledge is not always understanding. So we have to go beyond just educating the people. We have to change and redesign the system. So lesson number two, change the system, not just the people. And this is where we learned a lot from a physician leader by the name of Stephen Clark. He worked for the Hospital Corporation of America, a large hundreds of hospitals across the United States, and they tried the physician education. They tried putting policies of let's review these cases in peer review. It wasn't until they installed the hard stop that the world started changing. This was the key insight that we then spread across the country in dramatic fashion. Hard stop policies dramatically improve the results. So what is a hard stop? You could not have the baby without somebody reviewing what was the gestational age. So there could not be an elective delivery without reviewing it. And when it was less than 39 weeks, you had to have a medical indication. So that changed the workflow. That meant the default was we're going to put the schedule the delivery whenever the doc and the mom agree to do it. And leadership had to back this up. They had to say, no, we're going to enforce it. When a physician says this baby's going to be born under 39 weeks without a medical indication, we have to say, nope, you can't do that. So sometimes redesigning the system is more powerful or complementary than just trying to simply persuade individuals. So the third important lesson that we learned with early elective delivery was that alignment accelerates change. What do I mean by that? It meant that there were multiple forces, multiple organizations, multiple levers all agreeing that this was important, this was a priority, and this had to change. Professional organizations did it. So ACOG and other specialty organizations said it was important. Public reporting, where we published the results of hospitals, became important. Payment incentives changed. Multiple quality collaboratives where we learned and shared ideas emerged. And then the March of Dimes. The March of Dimes actually mobilized patients and came up with public announcements and public service advertisements to support that. It wasn't just one intervention. It wasn't simply the hard stop policy. It was that sort of the nation reinforced itself with the same message, all of the organizations coming along same and believing in the same thing. We can start with things like public reporting. So Leapfrog, a large national organization, first started publishing the hospital EED rates, and that changed the conversation. Suddenly, moms and other people, policymakers, they could see what your performance was at your individual hospitals. And hospitals compared themselves. So it created this sense of urgency that we have to get our numbers more in alignment with what the literature suggested. So measurement changed behavior. And then there was payment alignment. So one example was in South Carolina, where Blue Cross Blue Shield and the Medicaid changed alignment so that people wouldn't be reimbursed for elective deliveries less than 39 weeks. That got people's attention and dramatically made adoption much easier. There were learning collaboratives. I was part of a big national one called the Partnership for Patients, sponsored by the Centers for Medicare and Medicaid Services, CMS, 3,500 hospitals. And hospitals weren't simply told that we need to reduce the rates. They learned how to implement it, what it took to put a hard stop policy, how to deal with the pushback, how to share policies, how to alter workflows, and how to create the leadership spine and courage that it meant to take and enforce it. And it all happened simultaneously so that hospitals weren't afraid of a doc saying, I'm going to take my patients down to the hospital down the street, because they were all doing it. So sharing implementation strategy is just as important as sharing the evidence. Consumer-supported changes I talked about. Moms initially preferred to schedule deliveries for their convenience. That was really kind of easy. But once you told the mother that the risks were higher to her baby if she did it on a convenience basis, most of them really wanted to wait. Most of them, it was a no-brainer that they got to protect their baby at all costs. And so then patient goals aligned with clinical goals. So change happens faster when patients understand and support the reason behind it. So let's put it all together. All of these things kind of came up together. Strong evidence, leadership commitment, hard stop policies, a simple redesign, public reporting, payment alignment, learning collaboratives, patient support. Each one layered on was synergistic and reinforced the others. So let's go back to the bigger picture story that we have. What are the leadership lessons and we've learned from this? We often seek this magic bullet. What are the single interventions that can transform how things are done? How do we publish a paper and say, let's get it done? It wasn't one intervention. It was many interventions. It was alignment. It was when evidence, incentives, workflows, leadership, and culture all point in the same direction that we get remarkably and dramatically rapid change what you might consider transformation. So the lesson isn't that healthcare should always move quickly. In some cases, we can move too quickly, and that would be potentially dangerous for patients. That's not always a good story. But the lesson is that when we're trying to spread evidence-based practices, we should ask, are we only relying on education? Education is a weak, limiting factor that drives change in healthcare systems. Have we redesigned the workflow? It's going to potentially disrupt, and we have to help people deal with that disruption, understand and agree with and implement a new workflow and new system. Are incentives aligned? Or are people being pulled one direction and another direction? And whenever we can align incentives, we get much faster movement. Have we made the right action the easiest action? This comes out of human factors. People want to go where the path of least resistance, just like a stream that will break through and create new channels. Humans are just the same way. And we have to work really hard to make it easier to do the right things. And finally, are we helping organizations learn from one another? I love that. I love this idea that we're not mostly out there competing with each other, especially on quality. We need to learn from each other. Everybody's got something to teach. Everybody's got something to learn. Even the highest performing hospitals have weak areas, and the lowest performing hospitals have some strengths that they've learned along the way. It's this inside part of the organization that's figured things out that we need to spread both inside and across organizations. So as you think about your next improvement effort in your organization, ask yourself, are we simply asking people to work harder, or have we designed a system that makes the right decision the easiest decision? Sorry about that. The answer may determine whether change takes 3 decades or just 3 years. Now, if today's conversation made you think differently about leading change, share with a colleague who's helping guide innovation with healthcare. Thanks for listening to Viral Healthcare. I'm Bruce Spurlock, and I'll see you next time.